简小姐你好，嘿，我这里是凯旋医院哈，我们今天要做视讯问诊，那可能我先跟您核对一下一些基本的资料啦哈。今天是民国111年7月12号早上10点10分，我是凯旋医院的徐瑋泽医师。那因应疫情，我们要用视讯诊疗方式，请问您同不同意？
同意。
那我们可能先做身份核对请您把你的健保卡正面放在您脸的旁边我们做个截图。请问您同不同意这样截图？
同意。
好，那您等一下哦。好，那跟您核对一下身份，请问您的姓名？
简药品。
身份证字号
12232314484。
出生年月日
69年12月26。
好，那好了，谢谢您。那我们可能开始问诊您最近1个月的状况还好吗？
都很好。
您现在的工作做得还顺利吗？
还顺利。
最近跟家人相处的状况还好吗？
很好。
好有出门去做什么日常生活需要的事物吗？
出去买东西啊，有时候会出去公园走一走。运动一下。
那您觉得这个月以来您的情绪有没有什么特别的变化？
还好
那睡眠都还好吗？
可以。可以睡。
那最近还会不会像之前一样耳朵旁边有一些声音，有时候会干扰您？
有时候比较累的时候会。
那有没有听到什么特别的内容？比如说声音有跟你说什么吗？
通常就是杂音而已，内容还没有。
内容比较少了好。
对。
那会不会觉得说，最近出门的时候，比如说有人会特别注意你，那甚至会跟踪你？
不会。
会不会觉得说，好像会有人想要伤害你，或对你做一些不利的事情？
不会。
不会所以整体来讲，您的状况跟上个月比起来，您觉得有比较变化的地方吗？
差不多
那药物的服用上面有没有什么问题？
没有，我都有按时吃。
都有按时吃那是您自己吃还是家人会协助？
妈妈有时候会提醒我。
好的，那吃药会不会觉得不舒服，或者有什么副作用？
不会。
不会啦好，那其他的身体状况有没有什么不适的地方？
没有
没有您的家人也都没有说，比如说感染 Covid-19 或者是有一些上呼吸道症状啦
没有。
没有您本身都有打疫苗了吗？
有。
好那看起来您这个月的状况还都相当稳定，我们可能药物都会照原来的方式开立。好，那可能就等您有空的时候，您再请家人，或者是有空的时候再来我们医院过卡拿药。
好。
请问还有什么问题吗？
没有。
没有那我们今天视讯诊疗就先到这边如果您有一些急需的状况都可以随时再来我们的急诊或门诊然后或者是再打电话来社区科这边。好，那我们再保持联络，下次在视讯之前会先跟您告知。好，那谢谢今天就先到这边我们就先挂断了。
谢谢。
好，拜拜。Hello everyone, I'm Dr. 徐瑋泽. Today we are going to talk about the telepsychiatry. Especially during the COVID-19 pandemic, the application of telepsychiatry is more important than ever. So we'll begin with the history of telepsychiatry and the use of telepsychiatry during and beyond pandemic. First of all, we are going to give you a brief introduction of the history of telepsychiatry before pandemic. The use of telepsychiatry, or we should say the use of video conferencing in psychiatry began during the 1950s. So it's nearly 70 years ago. First, in 1955, the Nebraska Psychiatric Institute was using early video conferencing to provide group therapy, long-term therapy, consultation labs on psychiatry, and medical training at the Nebraska State Hospital in Norfolk. So you can see this first generation of telepsychiatry. The machine is very big, and this is a founder of telepsychiatry, which is Neubauer Ben-Shelter. And in the 1960s, the use of telepsychiatry began be used in clinical training or clinical use. In 1969, the Massachusetts General Hospital provided the first psychiatric consultation of adults and children at the Logan International Airport Health Clinic. And during the 1970s to 80s, it became increasingly common, expanding to most diagnostic and therapeutic interaction in clinical field. And by the 1990s, the telepsychiatry spread further across the world. Particularly, the use in Australia is popular, and the research began on its ability to facilitate access to care and overcome geographic obstacles, and how it compared to in-person care. And the use in Australia is especially due its larger scale of land use. So in rural area, the telepsychiatry is more popular than the urban area. In the 21st century, the field began to see the telepsychiatry as effective but slightly different than in-person care. And the research in outcome studies provided a platform for practical guidelines, such as the American Telemedicine Association, and the application to many cultures and the international manual has been successful. And the APA and the ATA begin to help to use the information to national organizations. So their conclusion is telepsychiatry is equivalent to in-person care in diagnostic accuracy, in treatment effectiveness, and the patient satisfaction. And the advantage of telemedicine is beginning to show in the 2020, in the beginning of the 21st century, and show it often saves time, money, and other resources. So as we can see, the telepsychiatry now is much different than telepsychiatry 15 or 60 years ago. And telepsychiatry use is also began to become more widespread in Taiwan. In the early 1980s, we are trying to introduce the first law to perform telemedicine in Taiwan, but the area is much restricted in certain kind of situation. According to the Article 11 of the Physician's Law, a patient in mountains area, in outlying islands, in remote area, or in special emergency situation may receive medical treatment by means of communication. And this is to say, in normal condition, you cannot use the telemedicine to treat or to diagnose these patients. In only special situation, you can use the telemedicine. So the situation is almost the same for nearly 3 decades. The situation is beginning to have some change in 2018. In patients under the following 5 special circumstances, the law begins to has more flexibility to use telemedicine to treat patients. That is to say, in 5 conditions you can use telemedicine in Taiwan. The first one is for acute inpatients, follow-up treatment within 3 months after discharge according to the established discharge preparation or service plans. The second condition is a long-term care service institution and cooperated with medical facilities, so the physician in such medical facility can have telemedicine to treat the patients living in long-term care service institution. The third condition is patients who are regulated by the act of integrated care of family physicians of the health authority require family physician to diagnose and treat due to their illness. The fourth part is telemedicine approved by the health authority. So some kind of a special condition given approved by the health authority, you can use the telemedicine within the 3 months after discharge. The final part is overseas patients who intend to receive or have received treatment from a domestic medical institution in Taiwan. So the condition is slightly reduced, but a normal condition we can still not use the telemedicine in our normal practice. In 2019, institution performing communication psychological consulting service can use the telemedicine to treat or to talk with their patients, including the medical institutions, the psychological treatment center or psychological consulting office. There are about 19 places of psychological consulting office are using telecommunication to see their patients since 2019. But the situation is going to change again during the COVID-19 pandemic, which we will talk about it later. Okay, if you have a more topic want to understand, you can go into the American Psychiatric Association. Their pages have telepsychiatry toolkit, and they have many kind of areas, and they have show videos introducing telepsychiatry. And we are going to talk about several aspects in the pages of American Psychiatric Association. First of all is the requirement for good outcomes. There are 3 prerequisites for good outcomes. The first of all is excellent clinicians. The second is a good program fitness for the telepsychiatry, including the organization function, leadership, and the right member workforce. And we have to use a whole team work to provide the telemedicine service. The third part, of course, we have to use the right technology, which ensure the good engagement, the clarity, and the reliable communications qualities for the patients and for doctors. The best of all, we have to and the option for clinicians to control the far-end camera, so the patient can see the one who he is talking to, or to control the angle of camera to ensure the better quality to their service. And there are different outcome area can benefit from the telemedicine. The feasibility rating of telemedicine is outstanding. There are now only rare technical issues such as poor visual image, pixelization of trouble communication, and turn talking in discussion. Those were all due to low bandwidth. But the popularity of 4G and 5G technology, this kind of question is rare today. And the validity rating is also outstanding. The evidence base relating to the validity has large focus on telemedicine in comparison to in-person. You can do nearly everything as you do in person, with only some minor exceptions. For example, the alcohol smell of the patient, or to do some kind of physical examination such as EPS, you still need to in-person care. And beyond this, nearly everything you want to understand can be achieved as the telemedicine. And the third part is reliability. The reliability of the telepsychiatry is also outstanding. The diagnosis has been made reliable with good interrate reliability. And the telemedicine has overcome the limitation in hearing and appear to facilitate language and culture matching by assist others. So you can have some translation assistance in telemedicine, so you can do many other things in-person care cannot do. The final part is satisfaction. Of course, satisfaction is extremely high among the patients, among the psychiatrists and other professionals. So if you have used telemedicine, you will be very satisfied and do not to give up with it. And the cost and the cost effective rating is similar to in-personal care or slightly better than in-personal care. Many studies has not been completed, but descriptive studies clearly indicated saving in time, in travel and money to patients and the providers. And the clinical measure ratings can divide it into interviewing, assessment, cognitive testing, and others is outstanding. And the disorders including depression, anxiety, psychosis, substance use, personality disorder, behavior, and many others are also outstanding. And the setting well studied, including outpatient, primary care, medical, are outstanding. But the setting least well studied, including emergency room in jail or inpatient unit and the school, is somewhat acceptable or similar to in-personal care, but we are not very sure about some specific areas. And there are also some interesting and preliminary findings. And for children and adolescents on the autism spectrum, it may be preferred to in-person or not in telemedicine use. And for adults with disabling anxiety, such as panic or PTSD, in-person care is often much better and show more in-person touch or more power of care in-person service. And preliminary studies in geriatric patients and across cultures are positive. It's quite the same or better in telemedicine. So the experience with therapy is trending very positively with surprising few problems. So you have to take care of some kind of a specific disease, but in most of time you can use telemedicine or telepsychiatry to serve your patient. And there are many evidence-based over telemedicine in over 2 or 3 decades. And the telepsychiatrist evidence base is substantial, and the satisfaction is extremely high among patients, psychiatry, and other professionals. The effectiveness of telepsychiatry is comparable to in-person care in terms of therapeutic engagement, quality of care, validity, and reliability of assessment and clinical outcome. So there are usually 2 kinds of study design: head-to-head or comparison, or non-inferiority. In 2 kinds of study designs, the telemedicine can show they are as good as traditional service, or maybe they are slightly better than the traditional service. So we can see from a review paper in 2015, there are many study, most of all the randomized control study that can show some effectiveness of telepsychiatry or telemedicine. And the most important is adherence. The most of the surveys show increasing adherence using telemedicine. So because they can save time, they can save travel costs, so the patients are more willing to use the telemedicine to cooperate with their physicians. And the many randomized control study also shows the telemedicine can improve the symptoms and also the quality of care, of life of the patients. So you can say there are many papers show the similar results. They can show that the telemedicine has a better quality or not, or at least as good as traditional treatment. So the evidence base for the telemedicine is formidable for children, adolescents, and adults. Regarding assessment and treatment, they are all the same. The preliminary study in geriatric patients and across culture are positive, as we have talked before. And there are a few populations in which it may be preferred in personal care, and as we show above, autism spectrum, severe anxiety disorder, and geriatric patients with some physical limitations. This kind of patients are recommended as a traditional impersonal treatment may be better for them. So later, psychiatrists adjust clinical care in a few ways to make it as personal as in impersonal care. This is very interesting. You can use a more turn of gesture in telemedicine, and it can help to check in to see how the patient is experiencing it, because you cannot see very slightly facial expression of the patient, so you may have to ask for the patient sometimes. And the verbal communication may replace the handshake, handing a tissue box and such. So if you have to show your compassion or you show some kind of emotional support for the patients, you have to say it. You cannot to do it, you have to say it. And in a particular examination item, another staff or accompanying person can help the telepsychiatrist to do it. So you can ask their family members or other kind of persons with the patients to do some kind of examination, and the telepsychiatrist can see it from the screen to see whether they are doing the right or wrong. And as we are talking, the final part is return of investment. The telepsychiatry may have a significant value add compared to psychiatric service in traditional settings. And the telepsychiatry in an emergency room can be used to improve connectivity with outpatient mental health service, as well as assist to care, closing the referral loop between emergency room department and another providers. And the telepsychiatry in an ER setting may reduce transportation costs, inpatient and the ED utilization, and overall hospital costs. And so if you want to consult some specialist in the ER, you can use telemedicine, and you can to see for the patients, you can see the doctor as soon as possible and not to wait a long time for them to see you in ER. And within pre-military care setting and the specialty care clinic, telepsychiatry service has demonstrated a substantial benefit to patients' overall health status, as well as a significant physical cost saving to medical group and delivery systems. And it can also improve the correctional system, such as jail and nursing home, and which translate into cost reduction. So, as many samples had to say, the telemedicine or telepsychiatry can reduce costs in our medical system. So, of course, the telepsychiatry used in all over the world, especially in the United States or in Australia, are growing fast. This is a paper who show the mental health service in 2010 to 2017. So over 7 years, the percentage of medical facility who provided the telepsychiatry is increasing from about 15% to 30%. So it's increasing 100%. So you can see the highest increasing rate is mostly in the rural area, in the southern area of the United States. So there are some advantage for the rural states to perform telemedicine, because it can save the most costs in their medical system. And we can also see here that the public facility has more percentage to use telemedicine. And, I think it's also because some kind of cost-saving policy for them. And of course, the most widely use of telepsychiatry is in outpatient service department. And most of the telepsychiatry service department provided Spanish, and some provided some non-English service for them. So you can say it can serve more patients than traditional in-person service, because you can use list of specialists to serve more people. And we can see from this table to see the association between state characteristic and Western state mental health facility over telepsychiatry. You can see the states receive such as SNHA funds or Medicare funding has higher percentage to offer telepsychiatry. And the states with more rural populations, we say before, the state who has a more wide land and these persons, they are tend to have a more telepsychiatry service, which is more economic for them. And we have talked about the evidence and the use of telemedicine and telepsychiatry before the pandemic. And during the COVID-19 pandemic, the telemedicine is increasing its use much than ever. We can see here, this is a trend in the use of telehealth during the emergence of the COVID-19 pandemic, first from the early 2020 in the United States. So you can see the change of telemedicine encounters are growing about 10 weeks later than the pandemic began. And of course, the patients visiting the emergency department is decreasing as the pandemic became worse. So there are papers who summarize the change in telepsychiatry regulation during the COVID-19 pandemic. There are total 17 countries in this paper. So nearly all of them, they are trying to put these regulations on the telepsychiatry and trying to make more person can receive the medical service via telemedicine. So you can also see the Taiwan here. The deregulation of law related to COVID-19 is of course yes in Taiwan. So the deregulation is temporary. That is to say, some kind of telemedicine is acceptable only during the pandemic. But after the pandemic, we cannot perform such telemedicine service anymore. So the limitations still exist, but somewhat become least during the pandemic. And the qualification required for doctors who practice telemedicine. This is still restricted to the doctor for the service in the telemedicine department. And in Taiwan, there are no restriction on the application of software they can use for telemedicine. So you can use anything you want to create a communication between the medical facility and the patient. So in Taiwan, you can also provide telepsychiatric care at the first visit in different conditions. And you can also give medical prescriptions via the telepsychiatry, and you can receive prescription outside the pharmacy, so you can deliver the medical service directly to the home of the patients. And this is what we do in 2020 and in 2021. And later we will give you some example of the telepsychiatry in Taiwan. And the insurance reimbursement for telepsychiatry is also exists in Taiwan. So our health insurance is including this part of telepsychiatry. And of course, the telepsychiatry during the COVID-19 pandemic, we still need some kind of a protocol for the mental health care. So this may be slightly different than in-personal care, and there are some kind of tricky points that we may pay attention to. First of all, the target population and the mentioned inventions can divided into 3 groups. The first line inventions is people with mid-intensity needs. This is to say the people with no known psychiatry or physical condition, they are beginning to show some kind of psychiatric distress due to the uncertainty or misinformation, or the financial problems or physical distance during the pandemic. So the telemedicine is very fit for these patients to receive their first time the mental health service. The second line intervention is patient with moderate or to intensity needs, and this is included the healthcare worker and the people providing essential service, and the people with a stable psychiatry or general medical condition. They are trying to refuel their medicine and to continue their care. And for the patient who have a COVID-19 in enforced self-isolation, but they still have some kind of need for their psychiatry service, the telemedicine can also serve for these people in isolation condition. And the third line intervention is the people with high intensity needs. For those people who have the worsening or uncontrollable psychiatry or psychiatry symptomatology, or the people grieving the loss of someone during COVID-19, or they have some kind of psychiatry emergency, such as suicide ideation, suicide attempt, or substance abuse. And the people at a risk of self-harm behavior or even harm to the others or harm from others. So this kind of intervention have to combine with the in-personal care. The telepsychiatry is to trying to buy some time for the emergency situation, and for we to give the resource for these people in directly conditions. We may need some kind of a semi-structured interview for the initial assessment during the telepsychiatry in COVID-19 pandemic. The first part is to explore current living condition, because you cannot see the person in face or in directly contact. So you have to ask them, such as their social network, such as their social support resource, and you have to explore loneliness and the individual subjective experience of physical distancing during the COVID-19 pandemic. And you have to ask their employment and the financial situation, and they may have some change or disconnection from the previous hobbies, leisure activity, and their coping strategy may become different during the pandemic. So this is all we have to understand in the mental health service. And the second part is we have to explore their psychological distress and their coping strategies during the pandemic. And we have to explore specific situations, thought, and emotion related to any perceived psychological distress. And of course, the third part, we have to explore COVID-19 diagnosis and misinformation about COVID-19. And we have to ask the patient whether they receive their examinations, or their antigen or their PCR test results, and we have to ask about their vaccination status. We have to ask their current symptoms, such as upper respiratory tract infection symptoms, and their understanding about the symptomatology and other kind of information about COVID-19. And we also have to give some kind of psychoeducation about the COVID-19 to the patients, and to try to understand whether they receive some misinformation about COVID-19 or they receive some kind of misinformation from the media or other related. And the first, second, and third line intervention is all different. The first intervention is to provide the service to the normal, or we say, health people during the pandemic. So you have to provide appropriate information about COVID-19 and the public health measures. You have to provide some of the strategy to stay physically, mental, or social healthy, such as physical exercise, or to try to help the patient to maintain their healthy daily routine, such as eating, sleeping, or some leisure, or as we say, exercise in their home. We have to give them some kind of advice regarding how to improve social interaction during the pandemic, and their small tip for training and practicing relaxation and mindfulness technologies. And we also have to provide information about any financial assistance available to the population in time of quarantine. And they will have to try to schedule a follow-up call for the patients. This is for the health, generally health people during a pandemic. And the second line service, including the providing strategy to cope with fear of spreading the virus to family, friend, or their colleague, and providing additional advice to self-care to those caring to others, and emphasizing the need to continue with any prescribed psychiatry or general medical treatment. And we have to encourage them and to try to emphasize the need of continuation of treatment. And we have to understand that the second line intervention should always be assisted with a environmental health specialist, whether in the same call or via a scheduled call to one, and follow-up call should also be scheduled with this population. So the second line service, most of the time we are doing the telemedicine service in Taiwan. So for example, in Taishan Psychiatric Hospital here in Taiwan, we are trying to shift the social, the community visit model to the telepsychiatry model during the pandemic. So we have to serve for those people who need mental health service resource but cannot to go out or to go to the hospital during the pandemic. And the third line of intervention include contacting emergency service, such as police or ambulance, and referring caller to specialized mental health care provider without losing contact with them. So we have to try to continue to talk to them until the in-person service can arrive to their house. And we have to try to contact a caller support person to assist or asking the caller to put on another call. And we have to try to provide emotional support to the person calling, or benefit of someone with high intensity need, such as with high risk of suicide or harming others. So this third line, as we say, we have to try to combine with other resources to help people in time for their need. So we have three phases of the telemedical service. The first phase is stay-at-home phase, so the outpatient care. The service loading is very high in this phase. We have to provide many kind of the consultation or other kind of information provided for the people with or without mental health, but their stress may be highest in this time. And the phase 2 is initial COVID-19 hospital search. And as the people infected with COVID-19 is growing, so many people are trying to go into the hospital for their service. Okay, in phase 2, we have to provide a patient with mild or no symptoms to tell them to stay at home and receive the teleservice. But for those with some kind of inpatient need but cannot receive the service in time, there are some kind of system like the tele ICU to use the kind of the portable device or the device at home to help the people to come to treat their illness or to wait for the ambulance to come. In the third phase, it's called the post-pandemic recovery. The patient may possibly stay at home with symptoms. They have a deferred serious condition and may have elective surgery and treatment delayed. In third phase, we are going to try to help them to return to normal and to provide the continuous follow-up for those patients. And the final part, we are going to talk about telemedicine use beyond pandemic, whether we still need the widespread telemedicine service beyond pandemic, or we are going to return to more impersonal care beyond pandemic. And there are an interesting paper discussing about the patient's attitude toward telepsychiatry during the COVID-19 pandemic. This is a nationwide study in the United States, and over 80% of patients experience excellent or good service for their telepsychiatry service, and over 60% of the patient remote treatment session as help as in personal treatment as they thought. The major advantage are they go commute, so they should not travel for a long time, and the flexible scheduling and the rescheduling for the telepsychiatry service. And the major challenges are missing the clinic and not feeling as connected compared to in-person care. And 64% of people will consider using remote treatment session in the future. So even they can go to the clinic by themselves, they are still trying to use the telepsychiatry in the future. And this is another paper who discussing the mental health care provided attitude toward telepsychiatry. And according to the study in the United States, the telepsychiatry was very well perceived among mental health care providers, and many would like to continue using post-pandemic. And we do the same questionnaire in Taiwan in Kaishan Hospital for nearly half of our doctors who doing their job by telemedicine during the pandemic. You can see the result here. In the United States, the experience using telephone to provide care are mostly positive. About 66% is excellent or good. But in the Kaishan Hospital, a major of the questionnaire is fair. So the experience using telephone to provide care is slightly not as better as a study in the United States. And the experience using video to provide care is more better in the United States, but not as better as in the Kaishan Psychiatric Hospital. So the major challenge in the Kaishan Psychiatric Hospital is, we can say, compared to the impersonal talking, cannot feel the connectivity between the patient and the doctor. And this one is a quality of communication. This may be a technology problem. And the third problem is for the patient. The patient is not as good as us for using the application for communication. So we have to try to spend more time to teach patients how to use their telemedicine applications. And the advantage or the positive feeling during the telepsychiatry service is more flexibility for the scheduling and to the time arrangement in hospital. And when we ask the doctor which kind of diagnosis is more suitable for telepsychiatry, in the United States, the highest percentage is affective disorders and anxiety disorders and PTSD. And in the Kaizen Psychiatry Hospital, the highest percentage is psychotic disorders, but it's low in the United States, in questionnaire in the United States. This may be due to the patient with psychotic disorder and can receive the community service is more stable in our community department. So it's not the active phase psychotic disorder. It's a chronic kind of psychotic disorder who receive such kind of service. And if we ask the doctor, what do you think such a diagnosis is not suitable for telemedicine? The highest percentage in the United States are psychotic disorder, but the highest percentage in our hospital for our doctor is personality disorder, ADHD, or the substance use disorder, such as alcohol or other kind of substance use disorder. And if we ask after pandemic, I would like to continue using the telehealth. The 88% of our doctor will use telepsychiatry in at least 25% of their patients. But in the United States, the survey shows about 1/3 of the doctors are willing to use the telepsychiatry service for more than 50% of their patients. So they show higher awareness for using telehealth service in the United States. And when we ask, the future use of telehealth will be determined by which kind of factors. They show higher percentage of accordance. This is to say the severity of the patient's symptom or the patient's the requirement and their likeness to use the telemedicine. So in this survey, we can see the quality of the teleservice in Taiwan may be not as good as the United States because we receive more restrictions before 2020, and we are trying to release some kind of regulations during the pandemic. But we are not prepared as good as the United States or compared to other countries or other facilities who perform telepsychiatry for a long time. So I think this is part of the thing we have to need to continue our telepsychiatry service and to improve the quality and to make it as good as in-person care. And this is another very important issue in the future, is we are going to considering the managing virtual hybrid psychiatry patient relationship in a digital world. So if we are going to media the patient-doctor relationship by video conferencing, the key considerations in administration is a jurisdiction issue associated with license, standard of care, more practice, and prescribing. So we have some kind of a protocol or guideline for this kind of medical behavior. And for operational and creating a telepsychiatry service tailored to patient setting while attending to administrative consideration specific to low setting is to creating sufficient emergency protocol for patient environment. So we have to combine with virtual world and the real world. If the patient are in a certain kind of real dangers, we have to shift one more to another. And there are also some kind of a clinical consideration, such as adapting clinical style to a patient and patient setting. So, and the managing virtual space and awareness of virtual disinhibition, rapport, and distraction, especially in patient's home or office environment. Clinician awareness of resource, cultural issue, and environment factors affecting patient in a remote environment with which clinician may not have a familiarity. But in a generation who are used to use a virtual world as their communication style, this kind of question may become more widespread, but also more easy for the patient or the doctor to understand and cope with. But it's still very important for us to improve our service quality in the future 10 or 20 years. Okay, we'll directly go to our summary. Telepsychiatry has been shown and has been proved effective before COVID-19 pandemic. And the telepsychiatry has a limitation in some disease such as autism, such as panic disorder. But for other disease, telepsychiatry are at least as good as in-person care. And telepsychiatry can enhance accessibility for the patient, and telepsychiatry can reduce costs, and it can be deployed emergently during crisis and provided directly service for the patients. And during COVID-19, the restriction of telepsychiatry were eased in all over the world, including Taiwan. And the satisfaction was high among care providers and the patient, but maybe some kind of different for United States or other kind of other countries. And we need a protocol to help us to apply to those affected by pandemic and provided some different service for the patient with a different need. Okay, this is end of today's topic. Thank you for your attention.